With that, I would like to introduce our first group of presenters. First up, we have Dr. Valerie Boyer, Dr. Leslie Schaller, Denise Croft, and Grace LaFaux, who will all help to facilitate our TAP partner site at the Center for Autism Spectrum Disorders at Southern Illinois University at Carbondale. The CASD is an interprofessional training and research center that provides high-quality services and leadership in the Southern Illinois region for individuals with autism spectrum disorder and their families. Their presentation today will describe what individual variables lead to a better fit with specific augmentative and alternative communication systems. So with that, I'm going to turn it over to them.
Hello. Thank you so much for the lovely introduction. Good morning, everyone. We are so excited to be here. As stated, our presentation is on a collaborative approach to assessing augmentative and alternative communication modalities for children with autism spectrum disorder, or ASD. We have many clients, or as we call friends, in our clinic who do not use naturalistic speech. So we have been exploring ways we can get them started utilizing some type of augmentative and alternative communication, or AAC, which we'll refer to it a lot as AAC. So which modality would be the best fit for them and how we go about that procedure. Okay, so to begin with our funding statement, we have our TAP logo here with our funding statement. We are a very proud TAP partner and to be within the TAP network because it truly makes the work we do at our center possible. So thank you, TAP, and thank you for having us. So today's learning outcomes. Through this presentation, you'll be able to describe protocols for augmentative and alternative communication, AAC, diagnostic therapy, discuss the interdisciplinary team model growing at our center, and then reflect upon how variables like challenging behavior, consumer preference, and social validity impact our assessment decisions. Okay, Shannon talked about this a little bit. We're going to back it up just a little bit and talk about our center, just in order to provide some context to the dynamics involved in our procedures and our approach to collaboration. So we are the Center for Autism Spectrum Disorders, or CASD, or as we call CASD, at Southern Illinois University, Carbondale. We are under the School of Psychological and Behavioral Sciences. We are an interprofessional training and research center that provides high-quality services and leadership for individuals with autism spectrum disorders and their families in the Southern Illinois region. Our center focuses on community service, student training, and research. So about us, when we say interprofessional collaboration model, so in terms of who and what we are talking about, for student training, our students are trained by speech language pathologists, or SLPs, board certified behavior analysts, or BCBAs, and licensed clinical psychologists. Our therapy groups are called Language and Learning Group, or L&L group. And in our Language and Learning Group, we serve clients ages 2 to 6 with a combination of both speech language therapy and applied behavior analysis therapies. In our clinic, we currently have 9 clients in our L&L group, and they either have a diagnosis of ASD or a suspected diagnosis of ASD. So some of them may be on our wait list for a diagnostic evaluation, but they can still come and receive services. Okay, so in this presentation and at our center, we talk a lot about interprofessional collaboration. So there's room for all of us in the sandbox. At our center, we really highlight our differences as professionals in a way that helps us understand each other's perspectives and also view other disciplines as a valuable resource. So for our assessment procedures we'll discuss today, we're going to be talking specifically about the fields of speech language pathology and applied behavior analysis. So in line with this picture, we just want to share how two different disciplines can exist at the same time. It doesn't have to be binary and either or model. We often talk about disciplines with conjunctions of, but or except. But instead of saying we have similarities, but we are different disciplines, we say, yes, we come from different disciplines, and together we can bring greater quality of care. So no pushing each other out of the sandbox. Okay, so just some more formal language for our disciplines. Speech language pathology. Speech language pathologists work to prevent, assess, diagnose, and treat speech language, social communication, cognitive communication, and swallowing disorders in children and adults. So we look at receptive understanding, expressive language, and then social communication. For applied behavior analysis, we're talking about the science of behavior change, increasing appropriate adaptive behaviors, decreasing challenging maladaptive behaviors, discrete and natural environmental teaching, and parent coaching. So on the left, you'll see is our speech crew. It's made up of 9 graduate clinicians. And then on the right is our BAT squad, which is behavior analysis and therapy, which is made up of 10 graduate clinicians and 4 undergraduate clinicians. And then they all have oversight by faculty consultants, SLP supervisors, and BCBAs. So typically in our language and learning groups, clients attend sessions twice a week for an hour of speech, followed by an hour and a half of ABA therapy. Except one of our 9 clients is receiving speech and ABA in a co-treating model. So they have a graduate student from each discipline working with them simultaneously. All sessions have supervision by a licensed SLP and BCBAs. When we have our students assigned to a client, we want them involved and have an awareness of all aspects of their client's care. So we ask that they observe the other discipline session with their client so they can see what they're working on or how they might approach their goals. We also hold monthly interprofessional practice meetings, or IPP. Typically, we have group supervisions divided by the discipline, and then once a month we have our interprofessional group meetings where we combine group supervision, and then that provides opportunities for our clients' teams to discuss, analyze, collaborate, and reflect together. And then here we all are at CAS following one of our IPP meetings, and we're in front of our new sign, which we're very excited about. You'll see a lot of them are actually wearing a shirt that we all have here. It says Speech Crew, BAT Squad, and Psych Pack, because we do also have psychology students who have oversight by a clinical psychologist, and they handle our diagnostic evaluations. So in terms of this presentation, we're mostly talking about our L&L groups, and speech and ABA. But I want to highlight our clinical psych and psych students too. Okay. Now for Valerie.
Thank you, Denise. Can everybody hear me okay? Denise, can you give me a thumbs up?
Yes.
You got me? Awesome, great. Hi, everybody. My name is Valerie Boyer, and I serve as a faculty consultant at the Center for Autism Spectrum Disorders at Southern Illinois University. I also serve as the program director for the speech language pathology program at Southern Illinois University. And I'm so happy to be with you today to talk about our AAC project that we have ongoing. My portion of the presentation is going to kind of outline how we got started and some of the literature that we have based our current project on. So first of all, augmentative and alternative communication we utilize at CASD as part of our multimodal approach to communication within those language and learning groups that Denise was talking about. And we provide AAC systems when we have kids who come in, which we frequently do, who have minimal natural speech. So we would consider them to be minimally verbal types of kids. Next slide, please, Denise. Thank you. We have a variety of types of AAC that we utilize at CASD, and we've been very grateful for funding sources like TAP that have helped us build an AAC lab out of CASD. We have low technology AAC systems like picture exchange communication systems, like the Big Mac system, which is the button that you see on this slide where you can record a single message with your voice. The client hits the button and then that message is spoken out. We also have high-tech AAC systems. We have several iPads that have applications on them that we would consider speech generating applications, meaning that if the client selects the particular button, they will hear speech generated from that device. And then we also have some dedicated AAC devices. Both of those are Nova Chats right now, but we are in the process of purchasing a Dynavox as well, so that we'll have several different dedicated AAC devices available for our clients at CASD to get used to, and also for our students to train on that are coming through the CDS program, the BAT program, and doing clinicals at CASD. All of the types of AAC that you see pictured on here would be considered aided AAC. So everything that we are talking about in terms of adding to our AAC lab is some kind of external physical component that's added into therapy sessions to provide a method of communication. Next slide, please. So some of the previous literature on AAC that we've utilized as we've kind of developed this project, we have three different pieces here that were all systematic reviews or meta-analyses looking at how effective AAC is in working with different forms of communication. So in this slide, we think about in what way can AAC help our clients to be more successful in growing their participation in one way or another. And what we see across these three studies of largely single subject designs with either children and or adults who have developmental disorders and or ASD is that AAC can be effective in a number of different ways. First of all, it can really help with providing a mechanism for communication that can enhance participation, that can enhance function throughout the day, and can enhance social opportunities for individuals utilizing AAC. Second, we see that AAC can have an impact on challenging behavior. And that's particularly true when you take the time to identify sort of the functional mechanism of that challenging behavior and match that communication function to whatever the function was of that challenging behavior. There's also some caveats in Walker and Snell about particular age ranges where it might be a little bit more effective based on their analysis. But generally speaking, AAC can have an impact on challenging behavior. And then finally, we think about AAC and its relationship to natural speech acquisition. And when you look across these meta-analyses and systematic reviews, what you see is that the relationship between AAC and natural speech emergence is a little more nuanced, meaning that it can have some positive impact on natural speech development, but that's a lot more individualized. But what we do know about AAC is that it does not hinder the development of natural speech. And that's really a point of emphasis within our programs and our instruction, so that when we have practitioners going into the field, they can have those conversations with families and individuals that introducing AAC early into the therapy process is not going to hinder the development or acquisition of natural speech. Next slide, please. This is some newer research, and you can see Kasari et al. Is where this research originated from, and I know everybody's really excited to hear from Kasari later on today. What this initial study looked at, and I'm pulling this table from the second study, which was by Almiral and colleagues, but the table does a nice job of summarizing Kasari's initial work. Kasari looked at introducing a speech generating device. So if you remember, the speech generating devices are more high-tech kinds of devices, either an iPad with apps or some kind of dedicated AAC device. And what they did was they introduced that speech generating device at different points throughout early intervention. And the early intervention models that they used, or programming that they used, were based on Kasari's program of the Jasper model, which I know she's going to be talking about later, and also combined with some elements of the enhanced milieu therapy model. And they had different groups which had SGD or speech generating devices introduced at different times. And they also used what's called a SMART design, where the child's response to the initial intervention sort of predicted where they would go next. And you can see that on here. For example, if you look at the no SGD group over on the left-hand side, you'll see that based on the response to that initial treatment of the Jasper and the enhanced milieu without a speech generating device, they either made decisions of the person was responding and so they continued that treatment, or the child was not responding and they intensified that treatment. In the no SGD to SGD group, the initial treatment was done without a speech generating device, and then a speech generating device was added in the second phase of the treatment. And again, that speech generating device was added, you can see, in the slow responder group. So the group that wasn't responding to the Jasper and EMT in the way they had hoped would have the speech generating device added. And then in the last group, you can see they had speech generating devices from the get-go. So from the start of intervention with the Jasper and the EMT, they had the speech generating device added in. And what they found was in the initial study that there was benefit once the speech generating device was added. So for the group that had it from the beginning, they saw improvements in particularly in communication when that speech generating device was part of that early intervention. And then for the group when the speech generating device was added, they saw benefit in communication as well. In the secondary study by Almiral, which again is where this table is taken from, they looked at longitudinal data. So they went back to these kids later on to see how things were going in terms of communication. And they found that the group that had the SGD from the beginning had better long-term communication outcomes than the groups that either didn't have the speech generating device or had the speech generating device added later. And all of this was with kids who were between the ages of 5 and 8. But the idea here was that introducing a speech generating device earlier in the intervention process had some long-term benefits for the participants. Next slide, please. This slide is about a policy statement. The American Speech Language Hearing Association was part of a multidisciplinary group in a joint commission that put out a policy statement on access to communication services and supports, including AAC. And what the policy statement wanted to emphasize is that communication access should not be restricted. And they highlighted some ways that sometimes communication might be restricted and kind of advocated against that, including things like a specific age at which AAC is introduced. The idea that you need to show success on a simpler form of AAC or success in some kind of pre-linguistic context before AAC is presented. The idea that your cognitive level or your level of language would dictate access to augmentative and alternative communication is something they advocated against. And then any other kind of prerequisite skill that might be a barrier to being able to access augmentative and alternative communication. And in fact, what they advocated for was that communication comes in lots of different forms, and that we should look for how do we add in communication supports that enable more participation in daily life. So a very functional framework, a framework that's consistent with the ICF framework and the World Health Organization principles of accessing communication, and the idea that communication is a human right. Next slide, please. Okay, so that leads us to our collaboration here at CASD. We approach our kids in our LL language and learning group, individuals, and the idea that there's no one size fits all approach to AAC. And that's really kind of how we're viewing this. What are the individual variables for these kids, and what is the protocol that we need to put into place that really allows each child and family to help collaborate with us on making decisions about the types of AAC modalities that we're going to introduce, when we're going to introduce those AAC modalities, how we're going to collect and review data, and then how we're going to make decisions and how we move forward regarding AAC. Next slide, please. So the individual variable piece that we're trying to gather some data on as we start to think about AAC modalities includes aspects of pre-linguistic skills. Those include joint attention. And one of the ways joint attention has been talked about is that for individuals with potentially stronger joint attention at the onset, they might be more suited for AAC modalities that are a little more complex, and those who don't have a lot of joint attention when they are getting started might need something where that joint attention piece is sort of built into the AAC modality itself. Imitation skills have been talked about as important. So how imitative is a child in terms of motor imitation and speech imitation. The stronger the imitation skills, oftentimes the thought is the more quicker they're going to be successful with AAC. Play skills have been talked about as individual variables that might kind of shape how quickly somebody is acquiring different types of skills, how interested they are in accessing AAC during play. And then the idea of symbol matching. So do we have a child coming in who's already able to match the symbol to the reference? So if we have two pictures and we have object, can they match that symbol to that object? And then finally, the idea of social validity is really important. And one of the things that we know from Moorcraft et al. Is that abandonment is a real issue in AAC. And by abandonment, what we mean is an AAC modality is selected, and then abandoned in a functional way, meaning that the AAC system is not being utilized throughout daily activities, either in the home or the school. And so what are ways that we can look at enhancing the likelihood that AAC is going to be successful and not abandoned? Next slide, please. So that leads us to our first case study, which is Tobias. I'm going to get us started on this case, and then I'm going to turn it over to Grace LaFaux to take over here. But Tobias is 6 years of age, so he's kind of in that range that we've seen literature in terms of introducing AAC. He comes into this project with a history of low-tech AAC and a very few number of manual signs. So he does sign, for example, he has a sign for more that he uses, and then he has a picture exchange communication type of system that he had been utilizing. And if you kind of look at the PECS framework, he was in about phase 3 of PECS. So he had independently selected, one picture. He would do that with some distance, and he was at the point of discrimination between preferred items in that phase 3. He does have a history of challenging behavior, including some self-injurious behavior, largely consisting of hitting his head with his hands. Next slide, please. So we did try and get some pre-linguistic data before we started the test, or before we started the AAC protocol. That included the early social communication scales, the ESCS, which is a structured behavioral observation that was implemented, videotaped, and then the videotape was reviewed. And it looks at, particularly we were interested in joint attention, and it also looks at behavioral requesting. And if we look at Tobias's data on joint attention specifically, the ESCS separates out the initiation of joint attention and the responsiveness of joint attention. And he was a kiddo who definitely was much stronger in the responsiveness to joint attention, meaning that he would follow things like points and gestures, but he had minimal initiation of joint attention. Next slide, please. In terms of behavioral requests on the ESCS, again, it separates out the initiation of behavioral requests and the response to behavioral requests. He did have more initiation in the area of behavioral requests, so trying to get access to something, than he did in shared social engagement. But in general, just like with joint attention, his responsiveness to behavioral requests was much stronger than his initiation of those requests. Next slide, please. We also did an informal play / symbol referent procedure, and we adapted this from some language in the Buchelman and Miranda AAC text. And what we did was we selected items that we thought he had a preference for, and we looked for the presence of functional play with those items. So playing with things in the way that they were intended to be played with, and he demonstrated that fairly consistently with 4 out of the 5 items. Then we also looked at his symbol referent matching. So we had 2 pictures and an item, and would he match the picture with the item? And he did that in 3 out of 5 of the items. So some demonstration of that symbol referent matching. And then finally, we used the Early Start Denver model checklist in our LL clinic. And so he was largely in the level 1 of the Early Start Denver model. He did demonstrate some skills in the areas of play, receptive, expressive, and social. A number of those skills had to be elicited. They weren't just observed, but he was demonstrating some skills in each of those areas. Next slide, please. All right, I'm going to turn it over to my colleague, Grace LaFaux, who is a fellowship student in the Communication Disorders and Sciences program and also pursuing her credentialing as a BCBA at Illinois University. So I hope you enjoy listening to Grace, and thank you so much for your time.
Thank you, Dr. Boyer. All right, so I'm going to finish out the first case study, and then we're going to talk about the next one. So for Tobias's case study, the protocol that we were using is an alternating treatment design. So we were looking at PEX, SnapCore, and Proloquo to go. PEX is a low-tech picture-based symbol system, whereas SnapCore and Proloquo, they are both apps on the iPad, and they are speech-generating apps. And so we were alternating between these three modalities in a systematic way. Next slide, please. There we go. So with Tobias's assessment, it ended up being a little bit more naturalistic just because we were trying to embed it into his therapy sessions. And so here we have the data from that. On the x-axis, we have our sessions, and then on the y-axis, we have the percentage of independent responses, and then blue is PEX, orange is SnapCore, and green is Proloquo to go. And you can see that because of his history with PEX, he started out as 100% independence, and then I think he ended up shifting, like going up into the next phase of PEX, and that's where we saw a little bit of a decrease in independent responses. But overall, the trends for SnapCore and Proloquo are increasing. There was a little bit more fluctuation with Proloquo, but there was a steadier trend with SnapCore. And we only had 6 sessions of data just because we started it about halfway through the semester, and the semester did end before we could completely finish it and get some more stabilization in the data. All right, you're good. Go to the next one, please. Thank you. And because his was naturalistic, we were able to observe his communication functions across different settings. So on our x-axis, we have the various communication functions that we observed, including requesting, refusing, labeling, commenting, questions, which is asking or answering questions, and expressing feelings and engaging in social routines. And then on the y-axis, we have the percentage of utterances that were within these categories. So for PEX, we see that his communication functions were very limited to requesting and answering questions just because of the phase of PEX that he was in. But with SnapCore and Proloquo, we saw more of a breadth across the communication functions. So, whereas he had been using PEX before, that might not be the best modality option for him just because it limits his language. Next slide. Thank you. And so to make like our final decision, we wanted to make sure that we had social validity. And so we considered things like what's important to the family, how can they best support Tobias? Since he was going to be starting school, he's 6 years old, what AAC system might help him achieve his academic goals and succeed in school? And then also what's most accessible to the family. So with PEX, a lot of materials are required just to make a new symbol. The portability is a little bit limited. It can be kind of bulky, whereas an SGD or speech generating device can be more portable and the vocabulary is very dynamic. So you can add new things, you can change it, and it requires very few materials. Next slide. So where is Tobias now? Currently, we're happy to say that he is waiting for his own device to use at home. We had somebody come in from Dynavox to do an assessment with him, and our data from our AAC assessment was able to support that, to receive funding for that. So he's still waiting on that. While he's waiting, his clinicians are continuing to work on AAC at the clinic. Right now, he has a 2x2 grid size, and he's able to produce multi-step utterances. So to say, I want bubbles or something, or I want the blue ball, he can say, I want blue ball. And it kind of goes through multiple steps just to produce like a request, which is super cool. He's able to scroll through on pages to find the symbol that he wants. Some of his current targets or goals in clinic include requesting, commenting, and then also relational and descriptive vocabulary. So again, working on the multi-step requesting, commenting on something like that requires joint attention, so like reading a book together, and then working with relational and descriptive vocabulary. So I want the bigger shape. This one is round, this one's blue, and so trying to build on that. He has had some trouble with discrimination in large arrays and position bias, but this I think has improved throughout the semester. So we've been kind of trying to trick him by moving his preferred symbols around on the grid and to different pages. And he's able to successfully navigate to the pages to find what he's looking for, which is super exciting. So overall, his assessment methods were successful, and we were able to support the funding of a personal device for his family with our data and provide a meaningful modality of expression for him. And before the end of the semester, because this is his last semester before he goes to school, we will conduct parent training to prepare his caregivers before he starts attending school, just to make sure that they have everything that they need and that they're competent with the device too. Next slide, please. All right, so that was our first case study. And our second case study, we're going to be talking about Gabriel. He's a newer client. He just joined us this semester. He is 3 years and 5 months old, and he's diagnosed with ASD. And his communication, when he first came to us, he's non-vocal. And before he came to us, he only had very limited experience with PECs. And he does have challenging behavior. So mostly tantrums that include self-injury, which I will talk a little bit more about later. Next slide, please. We have a video, and I think Leslie Schaller is going to talk about this first, and then we'll get into the video.
So I just want to make sure that everyone can hear. So I'm going to pull up the video, and then please let me know if you guys can see and hear the video. Oh, can everyone see that? Grace, can you nod? Okay. And then here. Can you hear that? Okay. So just wanted to show, so this is before we started the AAC modality assessment. So just want to highlight a little bit about how he presented before we provided any assessment for the communication. And then we'll show you subsequent videos where we are working on the modality assessment, and then what the end goal kind of looks like for him. So we're going to show you this little bit of a clip just to get an idea. Whoops.
Give it to me, George. I will help you. Here. That's cool, isn't it? Boy, you're falling off my leg, man. This could be a hard one. Okay. My turn, George. Thank you.
All right, so in that video, you could see that he was having a little bit of his tantrum behavior, which I think Grace will talk a little bit more about in a little bit, and then crying. And he does have often where he'll fall to the floor. I think in that case, it was hindered a little bit because he was sitting in another therapist's lap. But that was a typical behavior that he would cry, sometimes fall to the floor, hit his head on the floor, especially when denied access or items were removed from him. All right, Grace, I'll turn it back over to you.
All right, thank you. So now we're going to get into the methods that we used for Gabriel's assessment. So again, we used an alternating treatment design, but we wanted this assessment to be a little bit more structured compared to biases, just to improve experimental control. And we were able to learn from Tobias's assessment and shape the protocol a little bit more. So trial blocks were within different modalities, and we randomized them to prevent bias. So there were 5 trials within each trial block. And we tried to conduct at least 2 series, so that would be 6 trial blocks. We went through each modality twice, each session, and it was a comparison of PECs, the Big Mac button, and iPad with Proloquo app, and these were parent and clinician nominated. The parents had shared that sign language was aversive to the client, so we didn't include that, obviously, and then we tried to kind of pick some different things where we might see some variation in results. And first, we conducted a preference assessment to identify his most preferred item that we could use to contrive like requests, and that was dinosaurs. Next slide, please. So we evoked requests or mans for dinosaurs. We did have to modify the structure of our mans. Typically, the child mans for something, you provide them with the preferred item, and then you remove it to contrive another mand. However, a single dinosaur did not appear to be motivating enough for Gabriel to man. So we had to add dinosaurs instead of taking away the one he had. So eventually he ended up with like a whole army of dinosaurs on the table by the end of each assessment day, but it worked for him. So that was great. Our prompting hierarchy included the opportunity for independent responding for 5 seconds, and then we would systematically add verbal, model, and physical prompting with 5-second delays for each. And we collected data on prompt level and challenging behavior, which I have a little bit of a definition here. So typically we were focusing on tantrum, which included self-injurious behavior. And Dr. Schaller talked about that, where he might throw himself to the floor, which could result in injury, flailing his arms and legs until maybe they made contact with the wall or furniture, head banging the floor or walls, hitting his head with an open palm. And tantrum may or may not include crying, but we were more concerned with the self-injurious behavior just because that could be harmful to him. Next slide, please. And again, I'm going to pass this over to Dr. Schaller.
All right, hello. I'm gonna turn my video back on. So we wanted to show you guys a little bit of what the assessment looked like in terms of each of the modalities. And then Grace just did a nice job describing each of the modalities, but just to give you guys some supplemental visuals to see how he responded to each set. And then Grace will talk about the results. Let me make this. Here you can see he's using the Big Mac. Request for dinosaurs.
Dinosaur! Dinosaur! You can have that dinosaur. Good job asking, George. Good job asking. Wow, that dino's tail. Does it bend?
Oops, sorry, that got cut off a little bit, but at the very end, you could see him reaching over to the button. And so he just had to push the button, and then it was recorded to say dinosaur, and then he would receive the dinosaur after pushing the button. He did not have a history with using the button as far as we were familiar, so that was a brand new skill that he learned very quickly. This is how he did with PECs. There is a little bit of a delay, so I apologize for that.
You asked for a dino. Oh, there you go. Thanks for asking, George. There you go. Oh, thank you, George. You're the dinosaur.
So, and you could see that we were delivering the dinosaurs to him through the door or over the door, because he often, if he saw the dinosaurs, he would immediately run over and try to get them, and or sometimes exhibited challenging behavior. So we did that just so that he would be able to get into all of the dinosaurs. And here is him using the iPad.
That's great job asking. Dinosaur! Here we go. Whoa, what are you gonna do with that one? It's so small. It's a tiny dino. I think it's funny he looks after the picture. Dinosaur! Here you go, George. He knows where they are.
All right, so that was him using the iPad. So Grace will talk about the results, but you can see that he was doing very well overall with the modalities.
All right, so on the x-axis, we have our trial blocks, and then each trial block had 5 trials in it. And then on the y-axis, we have independence of, or percentage of independent responding. So if he was independent in 4 out of 5 trials, that would be at 80%, just to give you a reference. So for the first 6 sessions, we used like a 0-second delay, and we kind of based it off of like a PECS procedure, PECS phase 1. So if he would reach towards the object, we would full physically hand over hand him to request using whatever modality we had, just to kind of establish like the contingency, like first you have to do this step before you get the dinosaurs. And then after that 6th session, we moved into, or 6th trial block, we moved into a 5-second delay like I described earlier. So we would give him 5 seconds to independently respond. Then we would verbally prompt him 5 seconds until we did a model, and then 5 seconds until we did full physical. So we can see that he had like a very steady trend with iPad and PECs, which is like iPad's the circles and PECs is the triangles. With Big Mac, it was like a little bit all over the place, a lot more fluctuation. We actually, I think, at the 18th, we were very concerned because we almost eliminated PECs because we didn't see any independent responding until the 18th trial block. And then on trial block 18, he walked up to the PECs book, grabbed the picture and handed it to me without any prompting. Sometimes he likes to keep us on our toes. But after that, he had 100% mastery, 100% independence across all three modalities. So if he has 100% independence across three modalities, how can we make a final decision? Sometimes we would look at challenging behavior, which is the little X's on the X-axis. We did not see any challenging behavior throughout the assessment, so that didn't give us any information. Next slide, please. So to make our final decision about what might best fit for Gabriel, we consider both caregiver and client preferences. This will prevent device abandonment and facilitate Gabriel's communication. So his caregivers indicated that sign language was aversive for the client, like I discussed earlier. And for practicality purposes, they did not prefer the Big Mac button. You can only have so many limited phrases, and novel phrases would require new recordings. So it would just be too cumbersome to support his growing vocabulary. Other than that, they just indicated that whatever he wanted, we would move forward with. So next, we wanted to consider Gabriel's preferences. So we conducted a concurrent operant preference assessment between the iPad and the PECs. So this was 4-minute trials where he had access to both AAC systems. They were equally distanced from him, and he was able to use either one to request for dinosaurs. At each minute mark of the 4-minute trials, we would switch the positions to prevent side bias, and we conducted 3 of these 4-minute trials to see if his preferences changed over time. We do have a short video of what that looked like.
Yes, just to, I know this part is a little bit unique, so we wanted to make sure that we were able to provide a video of how he did with that.
Yeah. All right. Dinosaur. Dinosaur, George, there you go. Dinosaur. Dinosaur. Dinosaur.
And then we rotated it like Grace described, just to make sure it wasn't his right-hand side that he was favoring.
Dinosaur. It's when he hits it multiple times, it messes me up. He's like, this one's small. That was a Stegosaurus. He's like, this one is a little bit good. Dinosaur. Dinosaur, George. You asked for a dinosaur. Dinosaur. Get it. Oh, that one has a bendy tail, doesn't it? You like when they have bendy tails. Dinosaur. What we're gonna do is we're gonna have to join 3 left. 4 left. There's 5.
So as you can see, even when we rotated it, he still showed us that he had a preference for the iPad and making his little dinosaur army.
All right, so this is our graph of that preference assessment. So on the x-axis, we have the 3 different 4-minute trials. And then on the y-axis, we have the frequency of MANs. And you can see across all 3 trials, he preferred the iPad. So 100% of his, I think 41 requests were via the iPad. So that indicated a clear preference as to which one he would prefer. Next slide, please. So just to summarize a little bit, he achieved mastery criteria in each modality. We did not observe any challenging behavior. And then we were able to rule out one of the modalities because of parent preference. And then we used client preference between iPad and PECs, in which 100% of the 41 MANs for the preferred item were with iPad. So we had a clear path to move forward with. Next slide. So where's Gabriel now? Now that we're done with the assessment, we are focusing on our intervention. And so while other AAC systems might be used in the future, a bulk of his intervention is currently focused on the iPad just to catch him up a little bit in his expressive language. And he's doing very well with that. He just finished a program to systematically increase his grid size and symbol discrimination. And so I have that data here on the graph. So on the x-axis, we have our trial blocks. And again, there's 5 trials in each trial block. And then on our y-axis, we have the percentage of independence. The green is accurate independent responses, and then the orange is challenging behavior. So we were able to track like how that affected his responses. So in baseline, it was a 2x2 grid of 4 different preferred items. He had very low levels of responding, or independent responding, I should say. And then in phase 1, it moved back into a single system or single symbol system. So just one picture, just like he was doing in the AAC assessment. And then from there on, phases 2, 3, and 4, we added, we changed the grid size to 2x2. And we added like a series of blank symbols or other preferred items or neutral stimuli to try to get him to phase 5, which is where he had 4 preferred items. So it's just like baseline. And we did conduct correspondence checks to make sure that what he was requesting for was actually what he was wanting. So he would request, we would give him the option of the 4 different items. And then if he chose that the same one that corresponded to what he asked for, we would consider that an accurate request. So he's finished that, and now we're going to work on generalizing that skill to other settings, items, and people. And then towards the end of the semester, we do want to conduct parent training just to make sure that they know like what page we're on, and that they're competent in like increasing his communication moving forward as well.
All right, thanks, Grace. Nice job summarizing his success. So we talked a little bit at the beginning about, this different collaborative model where we have speech language pathologists and BCBAs, and we're both working toward, the same goal in terms of trying to identify effective modalities for some of our kids who don't have functional communication at this time. So Tobias's case and then Gabriel's case, I think, highlighted a little bit of the differences between maybe how speech approaches this assessment and then how we approach it from a behavior analytic perspective. But then also, I think there's a lot of similarities that we both look at. And so we went from, one specific type of model with Tobias, and then we're able to make some adaptations and modifications for Gabriel's, which I think we've learned a lot from and have been able to continue, or will be able to continue to make changes along the way for future clients as well. So just to highlight a little bit of the similarities and differences between the two ways that we really approach this. So similarities were that we used an alternating treatment design for in all cases. So we alternated between whatever the modalities were. So PECS, Big Mac, and then iPad. For Tobias, we did 2 different iPad programs, which is a little bit unique as well. We took into consideration parent and clinician nominated modalities to make sure that what we were assessing was going to be appropriate for the client. We really cared about functional communication, so making sure that we were using either things that were like functional items, so like preferred items, and also taking into consideration if there was specific things that would help improve functional communication and reduce maladaptive or challenging behaviors. And then also the client and parent preference, as I mentioned. Some of the differences between maybe how speech initially approached it and how we approached it. So we were replicating previous literature that has done this a few times. It's not been widely utilized, which is also kind of interesting. So the structure order that we presented the modalities in varied. So for Tobias, they did it in the same order every single time that they ran sessions with him. Whereas in Gabriel's sessions, we actually alternated it randomly. So we they just randomly determined each day which modality they were going to use first, and then did a semi-random order that way. The prompting strategies were also a little bit different. So with speech, they waited until the individual reached for the item and then immediately prompted them to then use the modality that was in place for that session or that trial block. Whereas as Grace described, we used errorless prompting initially and then did a least to most prompting. So a vocal and then a gesture or a model, and then we full physically prompted so that they had to come into contact with the contingency of exchanging the picture or touching the button, and then contacted reinforcement for doing that. We were very interested in challenging behavior. So you'll notice with Tobias's data, even though he did engage in self-injury, there wasn't data reflecting how often he was doing that initially. With Gabriel, we did track challenging behavior along the way. And as Grace mentioned, we fortunately didn't see any, which was great, but we would have taken that into consideration had there been maybe one modality where he admitted more challenging behavior or less challenging behavior. But in this case, it wasn't really a relevant variable. The termination criteria also was different. So initially speech was looking at just, we're going to do this for a set period of time, like 3 weeks, 4 weeks, etc. Whereas we had a very specific mastery criterion. So we wanted the individual to use the modality independently, meaning without prompts, and then they needed to do that consistently over a 2 or 3 session period, 80 or 100% of the time. And at that point, we would terminate the assessment and then move on to other things as Grace described. And then lastly, so even though we both were interested in the parent perspective and what parents were most interested in using, we also replicated some previous literature where we allowed the client to show us what their preference was. This is often, I think, overlooked sometimes, especially with non-vocal individuals, but there are ways that you can have or we can observe what the individual's preference is just by presenting different options and then measuring where they allocate their responding. And so as we saw with Gabriel, he was very clearly allocating his responding to the iPad, which was a good indication to us that that was his preference between the different modalities. So kind of circling back to this that we talked about in the beginning. So I think, the way that we approached this was, initially maybe we had our different ways that we were interested in assessing what the client's interest and the client's best success would be with the modalities. But we were able to really come together. So speech language pathologists and BCBAs, and then fortunately had Grace, who was kind of that bridge between us as well, since she's studying both speech language and behavior analysis, to really figure out what might be the best model to approach this. And so in the end, I think kind of the theme of our presentation is to really highlight how we don't have to do these things, discreetly. We can come together and we can find a model that, works best for the individual that you're serving, and then be able to, ideally have success with those individuals. And also just kind of highlighting the different strengths that we all brought. So SLPs, having that understanding of developmental norms, language structures, the form, content, and use of language, and then modeling and diagnostics. And then BCBAs, we brought having that systematic and objective measurement approach. So having that mastery criterion I described, very systematically measuring different responses to the different modalities, behavior interventions. So had there been any challenging behavior that was really detrimental or interfering, that would have been something that, we would have identified and targeted. We also identified the dinosaurs in Gabriel's case based on preference assessment. That was very systematic. That showed us that that was one of his most highly preferred items. Our data collection, I think, looked a little bit different and maybe a little bit more systematic to allow us to see which modality he would be most successful with by looking at prompt levels. In his case, as you saw with the graph, he was very quick to independently respond, but had there been a little bit more time that was needed, we could have looked at individual prompt strategies and seen maybe he responded to one modality using gesture prompts more so than full physical prompts, and that might have also impacted the decision that we went. And then the reinforcement, we tried to keep very structured. So it was like he would request for an item and then he would get 30 seconds access and then they would present the next opportunity. So we tried to keep it this very structured and systematic method where we could kind of make sure that everything was as consistent as possible. But as I mentioned, in the end, we were able to work together and we had a client-centered focus in which the goal, of course, was just to identify what might be the most successful modality for these individuals, so that we would have recommendations for the family, and then they could, of course, utilize that, or hopefully, be more likely to utilize that in other settings, such as at the home or in the community. This also allowed for, the potential for generalization. As Grace mentioned, at the end, we do want to make sure that we're coaching the parents on how to use these modalities, so that again, over the summer, and then into, the school year for Tobias specifically, that hopefully that will minimize some of that AAC abandonment, where they're continuing to have the schools use it or use it at home, because we have not only, data to support that, but also we've coached the parents, they've seen the success, and they would, hopefully have more buy-in at that point. So overall, just some considerations, when looking at different AAC modalities. So of course, effectiveness. I think sometimes, we're in those situations where we need an AAC device, and we maybe just pick stuff that's based on our own past history, or what we've been trained on, or what maybe we've seen successful for some individuals. But as we talked about in the very beginning, it's not a one size fits all approach. It should be based on that individual and the things that they need. And that could be based on a variety of different factors, right? So effectiveness, of course, is the most important one, meaning that, I want to use something that the individual is likely to be successful with. And how do I know that? Well, I need to assess it, and I need to observe them using it and see if there's improvement over time, or mastery over time. Social validity is definitely important. So we've had, I've seen situations in the past where it's like we're using a certain modality, but then you see the parents showing up or the caregivers showing up, and they don't ever have their textbook or the iPad or whatever modality it is that, we've recommended to use, or that they've had a history of using. So that's usually a pretty big red flag, right? Like, okay, well, they're obviously not even carrying the iPad or the textbook or whatever it might be. So making sure that we talk with the parent about what the barriers are, what their overall thoughts are, and trying to identify that as soon as possible. Because if they're not willing to use it outside of the therapy sessions, then that tells us that most likely it's, maybe we could be spending our time doing things that they would be likely to use, and then there wouldn't be that, potential for AAC abandonment. And then hopefully we provided a good demonstration of how we could also assess consumer preference. So again, even if they're not able to just outright say, hey, I want to use this, which in most cases is probably not likely, we can still objectively observe this person responded most to this assessment or to this modality. So that gives us reason to believe that they would prefer that specific item. Challenging behaviors, as we mentioned, had this been more prevalent for Gabriel, at least, we would have taken that into consideration. Maybe he responded perfectly to the iPad, but also had high rates of challenging behavior. That would have likely impacted our decision, and we probably would have gone with PECS then, or possibly the button, unless the parents didn't want that. But point being that we don't necessarily want to use a modality if we know that it occasions a lot of challenging behavior as well. Accessibility. So this is also important. So even if we have great data, we've seen success with an iPad, but then the family, maybe can't afford an iPad or doesn't have access to iPads, that should also be an important consideration, because some families can't afford them, or maybe they can, but then, they constantly break, and there's other variables that impact their ability to use them. So that should be a conversation up front, like, hey, if we're, we might go the iPad route. Is that going to be something that, is going to be feasible or available to you over the long run as well? And then feasibility. So, some of the limitations for any of the devices are just that, you have to carry them around. So like an iPad would have to be accessible outside of just the home and the school, and in other places such as the community. A PECS book, you'd have to bring the PECS book and have pictures and all that too. And I think sometimes those limitations can be why parents don't necessarily have buy-in, right? Because they're like, oh, I forgot the PECS book at home or the iPad at home. But those are all things that if we can identify up front, like the parent's not willing to carry the iPad or carry the PECS book, or doesn't have access to making pictures on a regular basis, those should be things that we take into consideration, and then should also influence how we or what we are recommending for some of our families.
Okay, so I'm going to quickly go over our future directions and next steps, because then I'll pass it back to Mary for the question and answer period. But overall, we want to continue to enhance our protocol to include more control, so we can replicate our experimental control, while encouraging a breadth of social validity measures analyzed. So that way we're, just as we adapted between one client to the other to change kind of how we were highlighting our protocols, we want to continue to do that so we can replicate it. And then, as Dr. Schaller was saying, with social validity, we have a lot of difficulty with abandonment, because typically it's chosen by provider or so provider preference and familiarity. So there's less likely to be abandonment when there's stakeholder or client and family buy-in. And then further, we'd like to examine the correlation between pre-linguistic data and protocol outcomes. So if we get a child and we can see their general makeup and profile of pre-linguistic skills, we can hopefully correlate and match them to a device sooner, which also helps with funding to get them to the devices sooner, and then also hopefully more success and outcomes for them. And then continue to expand our collaborative opportunities for both BAT and CDS pre-professionals at CAST. And then we just have some pictures, and thank you so much.
Thank you all from SIU for such a robust and informative presentation. We really appreciate it. There were a couple of questions, one I especially want to get to. In one of the videos, it looked like Gabriel had a pacifier. If he did, what were the considerations allowing this? And do you see a difference in when he had it versus when he did not?
So I think I could probably answer this. I'm his clinician. And so when he first started, he would bring pacifiers in, and sometimes he shows up with pacifiers, sometimes he doesn't. Sometimes he shows up and then he takes it out and he doesn't use it for the rest of the session. So there's really, I mean, we haven't like totally targeted that in sessions. We've just kind of allowed it. If it comforts him, like that's fine. But I haven't really taken data on like how that affects his behavior. So I can't say for certain, like on days where he had the pacifier, he engaged in less challenging behavior or more, you know, vice versa. But that's definitely a consideration that I'll take going forward. So thank you.
Excellent, thank you. And then we have a question that might be too big to answer now, asking about which programs are iPad specific. I would assume there are many, and it depends on the circumstance. I don't know if you all have a list, and if it would be okay, I can put your contact information in the chat so that you could send that, or we could send that out on your behalf to participants who are interested.
Sure, that would be great. We do have several apps on our iPads, and I'm happy to send out a list of the ones that we have and kind of how we got to those.
Okay, great. We'll include that after the presentation. Thank you so very much.